Everybody, welcome again to Surgery Grand Rounds. There is no support or no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until we get to the Q&A segment at the end of the talk. If you're attending online, you may enter your question into the Q&A section, but be sure to check the chat for your survey. If you are ABS certified and want NGHS to report your CME credits to ABS, please fill out our survey and give us permission to do that. And now it is my pleasure to introduce our speaker this morning. Phillip Rideout, MD, is a vascular surgeon at Northeast Georgia Medical Center. He received his undergraduate degree at Clemson University, followed by medical school at the Medical University of South Carolina in Charleston. He attended residency at Mercer School of Medicine in Macon, then completed his fellowship at the University of Tennessee in Knoxville. Outside of medicine, Dr. Rideout enjoys golfing and hanging out on the lake with family and friends. Please join me in welcoming Dr. Phillip Rideout.
Thank you all for having me today. They kind of asked me to do this a few months ago, and I'd given a talk similar to this when I finished fellowship to the residents, and I think this is pretty pertinent for you guys because most of y'all, when you get on service, all you want to know is, hey, just tell me what I need to know for the boards. So they're ready to get out of here, unless you're Ryan Anderson or Whitson or somebody like that, somebody smart. Yeah. So I have no financial disclosures. So in general, my kind of general rule of thumb is do not perform endovascular procedures other than diagnostic testing if warranted. They will lead you in bad places. My fellow a year above me, he went down the road of revascularizing an SFA with a stent and everything because he was a fellow at the time. He took his oral boards, and man, did they take him for a ride. So don't do that. So kind of starting off, we're going to run through the main topics that they're going to test you on in the oral boards. So carotid artery occlusive disease. So a stroke is a focal neurologic deficit relating to neuronal cell death with signs and symptoms lasting greater than 24 hours. And a TIA is a focal neurologic deficit with signs and symptoms lasting less than 24 hours. Approximately 30% of these patients go on to suffer a stroke within 5 years. So in general rule of thumb, they're going to give you a patient that probably came in with TIA type symptoms. You got to recognize it and then treat it. Don't watch it, okay? Pathophysiology, so ischemic strokes are about 80%, hemorrhagic are about 20%. A cardiac source and atheroembolic from the carotid share about the equal pathologic cause, okay? Cardiac source, most likely atrial fibrillation. So when you get these patients and they come, they're going to either give you a scenario in your office or the ER, make sure you get an EKG and make sure you check for AFib, okay? It's the number one single identifiable cause. The other, which they're going to push you towards, is the atheroembolic carotid stenosis. And then lacunar infarcts is kind of small vessel disease, hypertensive disease, but usually small vessel disease within the intracranial system itself, okay? Not fixable with carotid endarterectomy. So symptoms include dysarthria, dysphagia, aphasia, hemiparesis, hemisensory deficit, or amaurosis. You want to obtain a thorough history and physical, okay? You want to do this for every single patient they give you on the boards. They're going to give you a patient scenario. You don't want to go back and ask them the questions they already gave you, okay? You don't want to ask about information they gave you because it's going to upset the presenter, but you want to also ask additional information that they haven't given you that you think is pertinent, okay? They'll see it as a stall tactic if you keep asking them repetitive information or useless, but make sure you obtain a thorough history and physical. For any vascular patient, it's going to be very important to treat hyperlipidemia, hypertension, dual antiplatelet therapy, get them to stop smoking, okay, control their blood pressure, things like that, all right, diabetes, strict diabetic control, make sure you mention all that to them. And then examination, a full physical exam to evaluate deficits, cardiopulmonary exam, listen for carotid bruit, okay? You want to tell them what you're going to do quickly with a physical exam, okay? Ultrasound is the initial diagnostic test of choice. So a peak systolic velocity, these will be a little bit different based on whatever ultrasound lab criteria you have, but usually greater than 230 to 250 correlates to a greater than 70 to 80% stenosis for the peak systolic velocity. A peak diastolic velocity of greater than 100 correlates to greater than 80% stenosis. And then that internal carotid to common carotid ratio greater than 4, okay? CTA neck is kind of what, if I was doing this on the oral boards, that's what I would just go towards, okay? It's going to better define the anatomy and the degree of stenosis. It's going to evaluate for contralateral disease. 2D echo for an embolic source and preoperative clearance. So you also want to tell them that you're going to get pre-op clearance. Think about a little bit things like that, okay? Tell them you're going to manage them medically. Tell them you're going to start them on dual antiplatelet therapy, and then I'm going to get an echo and cardiopulmonary clearance, okay? That's going to be your number one risk factor is cardiac for these patients. And then consider an MRI. You know, they may or may not give you that depending on the severity of the stroke if the patient's an inpatient. Optimal blood pressure management, okay, things we talked about. So systolic less than 140. When you clamp, you can let them ride a little bit higher, okay. Glucose control, lipid control like we talked about, antiplatelet therapy and smoking cessation. So make sure you talk about these things because that's just going to give you extra points and let you blaze through the scenario, okay. If they're symptomatic, operate, okay. If they're asymptomatic, operate of greater than 70% stenosis. They're not going to give you a scenario on the oral boards where you're not going to operate, okay. So plan to operate. In patients with stroke or TIA, intervention should be performed within 2 days to 2 weeks. That's your window, okay? So if they give you someone that comes in, you want to tell them, hey, I want to get them in within a couple of weeks, all right? Intervention is not indicated for patients with chronic total occlusion or if they have like a severe disability, okay? So if they have dense hemiparesis, you're not going to fix them with surgery. Don't do surgery, okay? If they have a complete occlusion, you leave it alone. So, you know, I was asked beforehand to give some, you know, opinions on what to tell y'all for the boards. For any pathology that they're going to test you on, you really need to master a surgery, okay? Master one surgery. So you don't want to go in here, you don't want to talk about transfemoral stenting. I could do transfemoral stenting. I could do a TCAR. I could do a carotid endarterectomy. Don't do endovascular, as we said, but also just pick a procedure, stick to it, learn it, tell them what it is, okay? Tell them how you would do it and what to do. So carotid endarterectomy is your treatment for this, okay? You want to tell them, hey, I'm going to position the patient supine. I'm going to put them in a beach chair position with their head slightly up. I'm going to put a neck roll under their scapula. I'm going to turn their head in a contralaterally. We're going to make an incision along the anterior border of the sternocleidomastoid. I'm going to divide the platysma. I'm going to look for the anterior border of the SCM. I'm going to look for the jugular vein at that point. I'm going to be cognizant of my nerves, spinal accessory nerve, kind of superior and posterior to that SCM. I want to find the jugular vein. I want to find the facial vein. I'm going to divide the facial vein, which will lead me to where the carotid bifurcation is. I'm going to heparinize. I'm going to carefully dissect out the common internal and external carotid arteries. I'm going to control them with vessel loops. Heparinize with 80 units per kg, as we said, and then we're going to clamp. How would you clamp? Anderson, how would you clamp these patients? Correct, ICE, okay, internal, common, external. All right, protect your internal, and then it's going to be opposite on the way back, okay? De-air it through the external, flush it out, let it flush. Open your common, let it flush up the external, and then open your internal, okay? So you're going to go opposite on the way out. So there you go, clamp ICE. You're going to open along the anterior border with an 11 blade. I'm going to use pot scissors to open it. Create my arteriotomy craniocaudally. I'm going to put a shunt in. Go ahead and shunt. Okay, just do it. You don't have to know how to put a shunt in. Just tell them you're going to do it. All right. I'm going to shunt them. I'm going to perform an endarterectomy. I'm going to have neuromonitoring to confirm that I have no neurologic changes. If you shunt them, you're not going to have neurologic changes. They're going to know, okay, this guy knows what the complications are. You're going to tack your distal intima. You're going to close it with a patch. Okay, bovine, PTFE, Dacron, vein, whatever you want to do. Okay. I would just say I'll close with a bovine pericardial patch. You're done, all right? I'm gonna de-air the patch before completing it. I'm gonna flush it, and then I'm gonna unclamp. External first, common, and then internal, and then I'm gonna perform a completion study intraoperatively, okay? That's gonna let them know you're thinking of technical difficulties. I'm gonna look for any thrombus. I'm gonna look at my distal endpoint. I'm gonna look past the distal endpoint into the internal carotid artery, make sure I have continuous forward flow, okay? Continuous low velocity forward flow. You're done. Wake up, perform a neurologic exam, okay? They're going to give you scenarios where, you know, after they wake up, the complications are going to be that they're going to have a postoperative stroke, okay? Think about it. I know we've talked about it in surgeries. Think about kind of the routine, stepwise manner how to get through a postoperative stroke, okay? If you're in the room, you're going to go ahead and reopen, all right? You're going to reopen. You're going to take a look. So here, let me run through this real quick. So carotid, you're going to clean out the disease here on the left side. All right, you're going to clean that out. You tack your distal intima here. You're going to sew your patch on. All right. So they may ask you for extra credit, high exposure type stuff for higher lesions. So preoperatively, you're going to plan for nasotracheal intubation. You can divide the occipital artery, which will run right by the hypoglossal nerve, okay? You can divide the digastric muscle, the anterior border, divide it sharply with scissors. Division of the stylohyoid, never had to do it. An anterior subluxation of the mandible, don't recommend it. So complications, most common injury is hypoglossal. Tongue's going to go towards the side of the injury. Post-op thrombosis, so re-explore immediately, search for a technical defect and fix it. I know I've asked y'all this before about the 3 Fogarty catheter, so use a 3 Fogarty if there's thrombus. You want to pass it. First, you want to measure from where you are to the tragus of the ear, okay? You're going to pass the Fogarty up to that point, gently inflate it, and pull it back. Do not send it far up. You'll get a cavernous sinus fistula and you'll kill the patient, okay? So if there's bleeding, immediately open the incision if evidence of airway compromise, and then re-explore and fix the bleeding. From the post-op thrombosis standpoint, if they have a stroke, I would say if you're in the room, you're going to look at it, you're going to reopen. If there's nothing there, you're going to perform an on-table carotid angiogram and then try and do a thrombectomy, okay? That you're going to say, hey, I would consult Dr. Sung Lee. He's awesome. He's going to take care of it for me. And they're going to say, you're at some random hospital. He ain't available. He's in Hawaii visiting, his old house, okay? So you're going to have to work through it, all right? So bleeding, they'll give you a scenario, hey, post-operatively 6 hours later, patient's on the floor, he's having respiratory compromise, you want to go see him immediately, you want to take care of it at the bedside, you want to reopen the incision, okay, if they're having problems, and then re-explore and fix the bleeding. And then the other one, hyperperfusion syndrome, can last for up to several weeks after surgery, okay? The actual windows, like 7 to 10 days, is kind of the highest risk. So these are the people that go home, they don't take their medication, their blood pressure gets high, they get swelling on the brain, they have seizure-like activity. I've seen it once, it's terrible. Aggressive control of blood pressure, CT their brain, so they're gonna come back in with altered mental status and things. You wanna get a scan, admit them to the ICU, get a CT of their brain to make sure they don't have hemorrhagic conversion. You wanna do seizure prophylaxis, and you wanna get their blood pressure down, okay, reduce the swelling on the brain. Abdominal aortic aneurysms. So this is going to be kind of another big topic for them, okay? So focal dilatation of the artery to a size greater than 50% of normal. Normal aorta is 2 centimeters, so anything over 3 is considered aneurysmal. They're going to give you something that's 5.5, 6, 8. They're going to give you a big one, okay? Suprarenal aneurysms extend above the level of the renal arteries. They require reimplantation of one or both renals with open repair. Guess what? You don't have to describe to them how to do this. You just tell them you're going to do it, and they give you credit for it, okay? Juxtarenal comes up to the renal vessels less than 1 centimeter, requiring a suprarenal clamp, even if briefly. Then infrarenal is the most common, okay, 85 to 95%. You're going to either ligate or reimplant the IMA. Reasons to reimplant the IMA are what, Dr. Whitson here? Correct. So this is where the history and physical is important. You got to ask them beforehand, hey, have they had previous intra-abdominal surgery? Have they had previous colon surgery, okay? I can guarantee you that if you don't ask that, they're going to give you a problem with blood flow afterwards, okay? So ask them and saying, knowing that from a blood flow standpoint, I would like to know, have they had any previous open operations? Have they had any previous colon surgery, okay? And then increased risk of rupture in females. Positive family history, make sure you ask about family history when you're doing this, okay? Smokers, hypertension, and COPD. Is diabetes a risk factor? It's protective, correct, yeah. Why, do you know? No, it reduces inflammation. It's with the MMP9s, actually. Matrix metalloproteinases, so MMP9 is kind of the main one, so it's protective. Not clearly understood. All right, so ask about risk factors like we talked about, cardiac, pulmonary, renal, okay? So you want to make sure you optimize these prior to surgery. You're going to ask about abdominal and back pain, family history, physical exam, check for palpable mass, tenderness palpation, check for other aneurysms, okay? Thoracic aneurysms, 13% of people with infrarenal will have a thoracic. Popliteal and femoral is about 15%. If they have popliteal, they have a 50% chance of having an infrarenal, okay? So it's much more significant. If they have one on one side, 50% chance they have it on the other. For a femoral, it's about a 35% chance. If they have a femoral aneurysm, they're going to have a abdominal aortic aneurysm, okay? So, that's what it says in contrast. If they give you somebody and hey, they got a palpable mass behind their knee, which it may be, pulsatile mass, then you want to check for an infrarenal, and that's something you got to address, okay? There's your rupture risk there. You don't have to really, spout that information off, but, pretty significant when you get to that 6 to, 7 and over 7, it starts to go way up, okay? So mainly used for screening from an ultrasound standpoint. Operator error is definitely present. It's going to be, size is going to be a little bit off. CTA is going to be your number one thing to go at, okay? You want to tell them, hey, I want to look at the celiac, the SMA, and the IMA. I want to make sure that they're widely patent. I want to check that the renal arteries are patent, and I want to know the location of my renal vein, okay? Is it in front of the aorta, or is it behind the aorta? Because if you don't really kind of pay attention to that or let them know you're thinking, when you clamp, they may give you a clamp injury of the renal vein behind the artery, okay, behind the aorta. So you want to just let them know that you're thinking about that. MRA, I wouldn't go down that road. There's no radiation limited availability, but it's poor enhancement of the calcification, not getting contrast, okay? From a management standpoint, decision to operate relies on 3 factors: a risk of rupture, which is size, risk associated with the payer, and the patient's life expectancy. Again, you're going to operate on these people, okay, on the boards. You operate on all symptomatic patients if they have a greater than a 0.5 centimeter size increase in 6 months, as well as for females 5 centimeters and for males 5.5 centimeters. And then remember, you want to optimize them medically before, okay? So you want to tell them, hey, I want to do optimal medical management. I want to get them to work on stopping smoking. I'm going to control their blood pressure and start them on a statin. You don't want to put these people on dual antiplatelets because you're going to bleed. So again, positioning. They're going to ask you to do the procedure. You're going to tell them, I'll put them flat in bed. I'm going to put the arms extended. I'm prepping nipples to knees. I'm going to put an NG tube down, confirm it's in the stomach after insertion. We're going to use cell saver. We're going to use a midline laparotomy, confirm our NG tube placement, transverse colon. We're going to mobilize superiorly. All the small bowel goes to the right in the right upper quadrant. Come right down on our aorta, which you'll be looking at. We're going to be looking out for the inferior mesenteric vein, then the left renal vein. We're going to take care of any lumbars that we may identify. We're going to find our renal arteries proximally and our iliacs distally. I'm going to, heparinize, okay? So you have to decide whether you're going to do an aorta bifemoral bypass, a aorta biiliac, or just a tube graft. If they're going to give you an aneurysm, you're going to do a tube graft. If they give you, aorta iliac occlusive disease, you're going to do an aorta bifemoral bypass, okay? You're going to clamp distal first after heparinization. You're then going to clamp just below your renal arteries. You're going to open the aorta along the superior aspect. You're going to go up to a non-aneurysmal segment and kind of bevel it down on the sides, okay? That way you can sew your tube graft in using a 4-0 Prolene suture. And then you're going to sew once you sew the graft in proximally, move your clamp to the graft. I'm going to release my proximal clamp and ensure hemostasis. I cut my graft to length. I sew my distal anastomosis with a 4-0 Prolene. Just prior to completion, I let it back bleed. I de-air it, make sure there's no bleeding, release my clamps, okay? You also want to close the aneurysm sac over the graft, okay? Make sure you say that and then tell them, hey, that's to prevent an aortoenteric fistula. That takes that off the table because they know, hey, this guy's thinking about it, you're good. They're going to try to move on to other stuff, okay? And then they're probably going to give you a postoperative bowel ischemia, to be honest with you, because they know that you know what the aortoenteric fistula complication is going to be. You want to also close the retroperitoneum over the graft if there's aorta bifem, where there's not a whole lot. What are some other things you can do to get closure over that? Omental, make an omental flap. Tell them, hey, I'm going to make an omental flap, okay? So if you can't close it, they say, hey, there's not enough retroperitoneum, say I'd do an omental flap, or I'd put a large bovine pericardial patch over it, okay? Don't do, when I was a fellow, one guy, a surgeon, in his operative note dictated small bowel gently laid over graft for protection. A guy had an aortoenteric fistula, it was a mess to deal with, okay? Kind of hard to defend yourself in court there. And then when you're doing an aorta bifemoral bypass, make sure you tell them you're tunneling under the ureters, okay? You don't want to go on top, just say it, quickly. Hey, when I tunnel my graft, I'm tunneling under the ureters, okay? You prevented ureteral obstruction. Inspect the small bowel and colon prior to closing. Close, leave your NG tube, put them in the ICU, okay? NG tubes stay, guys. Don't take them out day one. Aortoenteric fistula is kind of one post-op complication they're going to give you. This is going to be someone who comes in months to years later, okay? Ileus, just keep the NG tube NPO. Bloody BM, leukocytosis, lactic acidosis is going to be the one they're going to give you. Emergent endoscopy, okay? You cannot do a rigid procto. You need at least a flex sig so you can see. If there's patchy areas of ischemia and no evidence of peritonitis, you're going to do IV fluid resuscitation. Antibiotics is key in serial abdominal exams, okay? If there's full thickness ischemia and evidence of peritonitis, a laparotomy with ankylostommy, okay? Mesenteric ischemia, 4 types, right? So embolic, approximately half of them are embolic. most commonly from atrial or ventricular thrombus or valvular lesions, strongly associated with arrhythmias and previous MI. They're going to give you somebody that comes in, they had a heart attack, 2 weeks before that, they had a stent put in, they had a kind of an interesting postoperative course with episodes of dizziness. They've been kind of dizzy when they got home, and it's undiagnosed AFib. They formed a thrombus, they shot it to the SMA, okay? Most commonly lodged within 3 to 10 centimeters of the proximal aspect of the SMA. There's classic ischemic pattern with sparing of the proximal jejunum and the transverse colon, okay? Thrombotic is approximately 20%, so they have pre-existing atherosclerotic lesions or a dissection, usually atherosclerotic, and they thrombose, okay? You get pan-ischemia of the gut because it knocks off the first part, all right? And then non-occlusive NOMI associated with anatomic arterial or venous obstruction, so usually after low cardiac output, someone's in the unit, sick as a dog, heart failure, sepsis, pressors, things like that, okay? Radiographic findings, you're not going to see a whole lot of disease proximally. They're just going to have narrowing of the vessels, tiny vessels, that kind of thing, okay? High mortality regardless of treatment because this is multifactorial. And then venous thrombosis is approximately 10%. You get a venous obstruction. It's kind of like intestinal phlegmasia, leads to edema, distension, infarction. It's kind of a subtle, insidious onset. People come in with a several-week history of abdominal pain. Primary is idiopathic. Secondary is trauma, surgery, cirrhosis, pancreatitis. The main things we usually see is kind of cirrhosis, pancreatitis, liver disease, okay? Cancer, dehydration, hypercoagulable syndromes. So these symptoms in all mesenteric ischemia range from chronic abdominal pain to acute severe. They're either going to give you a patient that you see in the office that's been going on for 6 months, 8 months. They've had $1 billion workup. Nothing's ever been figured out, okay? Or they're going to give you someone that comes in to the ER who's got abdominal pain, lactic acidosis, and is very sick, okay? Classic finding, pain out of proportion to exam, okay? So don't let a physical exam, especially in real life, fool you, okay? Patients rolling around, writhe around in pain, complaining of their stomach. You push on them, you're like, man, this guy wants some Dilaudid. Don't let that mess you up, okay? You may see nausea, vomiting, changes in bowel habits with the chronic form, so they'll range from kind of constipation to diarrhea. They'll kind of go back and forth when it's more chronic. You may see acute peritonitis with abdominal distension, absent bowel sounds. That's probably the one they're going to give you. Lab values, for all these, you want to kind of say, hey, I'll do a thorough physical history. I'd do an abdominal exam. I'd see, do they have any signs of peritonitis? I get some basic labs. I don't know what a CBC, lactate, hemoglobin, those kind of things. Renal function panel, I'd resuscitate the patient, start them on antibiotics, things like that. However, for these, they may give you a pretty benign stuff. Hey, their lactate's elevated, but everything else looks pretty good, okay? Don't let it fool you. You may see atrial dysrhythmia, so definitely get an EKG, okay? Abdominal x-ray, not going to be overly helpful. You could start with that just from a process standpoint, kind of working through. And then, they may say there's pneumatosis or portal venous gas, and then a duplex, wouldn't go to that, but a CTA is going to be your go-to, okay? Let you see both, rule out other causes of pain. And then, angiography is more for us, less for you. I wouldn't really do that on the oral boards, okay? Treatment, volume resuscitation, correct the acidosis, administer prophylactic antibiotics, anticoagulate to prevent further propagation of thrombus, put in a urinary catheter for strict I's and O's, central line, A-line, NG tube, okay, and then take them to operate, okay? Embolic, you're going to do a laparotomy. You're going to control gross spillage, frank dead bowel if that's present with resection and temporary closure. Pull your transverse colon superior small bowel to the right upper quadrant, mobilize the duodenum to the ligament of Treitz, and then palpate the root of the mesentery for the SMA. You want to dissect out the SMA, proximal and distal control, heparinize them. For embolic, you want to make a transverse arteriotomy, okay, Fogarty catheter proximally and distally to ensure inflow and outflow, and then close with an interrupted 5/6/0 proline, okay? Inspect the remainder of the bowel, resect dead bowel, temporary abdominal closure, and bring it back. You guys do this every day, okay? For thrombotic, same thing, okay? You just need to tell them how you're going to get there, okay, how you're going to expose the SMA. And then for a thrombotic, they're going to have a bunch of atherosclerotic disease. You're going to do a longitudinal arteriotomy, and then you're going to do an endarterectomy and Fogarty it out, and then sew a patch on there, okay? Use vein patch because it's going to be infected. They're going to give you this dead bowel and everything. Don't put Dacron or anything like that in there. Don't use PTFE. Tell them you're going to take saphenous vein from the proximal aspect of the thigh, okay? inspect the remainder of the bowel, and then temporary abdominal closure, bring them back, okay? Non-occlusive, you can give heparin, you can correct the underlying process, and then if there's non-viable bowel, you want to tell them, hey, I'm going to heparinize them, I'm going to put them on antibiotics, I'm going to do serial abdominal exams, I'm going to resuscitate them, I'm going to correct their underlying issue of what's driving this, and then if they have peritonitis, they're getting surgical resection of that necrotic bowel, okay? Venous thrombosis, same thing. Fluid resuscitation, correct their coagulopathy, try and figure out why they got it, and then resect non-viable bowel. You know, the catheter, the thrombolysis, suction thrombectomy stuff's usually kind of an IR standpoint, difficult to get there. They'll get there through various ways, whether that's transhepatic or splenic vein. You know, if they're going to ask you to do this on the boards and you go in and you do it, then you can make an incision in the SMV, IMV. You can run a Fogarty up and try and get some of that clot out there, okay? But I don't know if I'd go that in depth with it. All right, peripheral vascular disease is going to be kind of one of your bread and butter things, okay? Usually secondary to progressive atherosclerotic disease, lesions. History is very important to determine the chronicity of event. Contralateral pulse exam is very important, okay? If it's acute and they're palpable on one side and they're not on the other, you better be real worried, okay? If they describe someone who's a claudicant and smoker for a long period of time, they develop a diabetic toe ulcer, that's a different scenario, okay? Ask about risk factors. Again, there's 5 things. Just treat them, okay? Hypertension, hyperlipidemia, blood pressure control, blood sugar control, get them to stop smoking, okay? Put them on dual antiplatelet therapy, put them on a graduated walking program. You check all those boxes, you're good. Can also be due to an acute embolic event. So again, contralateral pulse exam, check them for AFib, get an EKG, get an echo. For the embolic event, you want to treat it like acute mesenteric ischemia with a transverse arteriotomy, okay? If it goes to the common femoral artery, just transverse arteriotomy, embolectomy, close it, okay? Symptoms range, so they're going to start out at long distance claudication, lifestyle limiting claudication, rest pain, and then ulceration or gangrene. Claudication is muscular pain elicited by walking and exercise, relieved with a short period of rest. Critical limb ischemia is going to be persistent, recurrent rest pain requiring opiate analgesia for more than 2 weeks, and an ankle systolic pressure of less than 50 or toe systolic less than 30. They're not going to ask you all that, just know it. They may give you a history like that, okay? Pain's usually worse at night. It's relieved with dependency. So they're going to say, hey, when I'm flat in bed, I wake up in the middle of the night, my feet hurt. I have to hang my foot off the bed to make it feel better. I now sleep in a recliner with my legs down. It makes it feel better, okay? So again, risk factor modification, exercise, medical management, they will hammer you this on the boards, okay? Patients with rest pain, tissue loss, and gangrene are at greater risk of limb loss and cardiovascular mortality. So PAD is a coronary artery disease equivalent, okay? So kind of make sure that everything else is okay as well. So start with a full history and physical. You want a duration of symptoms. Have they previously had any surgeries or interventions? Full bilateral pulse exam, full neurovascular exam to assess the degree of limb ischemia. So, viable. They're going to have no tissue loss, no sensory loss. They're going to be pretty normal. They're just going to claudicate at long distances, okay? A 2A is salvageable with prompt treatment, so it needs to be done in the next 24, 48 hours. So they're going to have some sensory loss and no muscle issues, okay? And then their weakness, their signals are going to be weaker in their foot, okay? 2B, you have to operate on immediately, okay? So for the oral boards, it's real important to differentiate between a 2A and 2B. The only difference between those is that in one, you're going to have sensory loss and not motor loss. For a 2A, for a 2B, you're going to have both sensory and motor loss. You got to operate on those people, okay? You got to take them then. And then 3 is mummified foot, okay? They have no motor function. They're paralyzed. It's been like that. It's mottled. That's an amputation, okay? So workup, if you see them in the office, which a lot of these people you are going to see in your office, you're going to get an arterial duplex, with an ABI. You want to know what the general values are there. If they give you an ABI of 0.4, it's pretty severe and you want to act on it quickly. You can do a CTA, abdomen pelvis with runoff, or you can do a diagnostic angiography, okay? So again, if they give you a SFA lesion, don't say, I would, get across this, I would, put a 7-French sheath, I'll do Hawk atherectomy and drug-coated balloon angioplasty. Then you're going to have, it's going to go down, their SFA is going to be down in recovery, they're going to have showered everything to their foot, and you're now going to be doing a femoral cut down with embolectomy, you're going to be doing a below knee cut down with embolectomy. It's going to take you in a bad spot, okay? So you want to get your targets. So inflow, outflow, conduit, okay? Those are kind of your three principles there. So you want to know what your inflow is on the angiography, you want to know what your outflow is on the angiography, and then you want to know conduit. So you're going to tell them, hey, I'm going to, preoperatively, I'm going to get cardiac clearance, I'm going to order an echo, stress tests on their heart, make sure they're okay. I'm going to get vein mapping of their bilateral lower extremities to ensure that their veins greater than 3 millimeters, so it's adequate conduit for bypass. And then if it's not, then I can use PTFE, okay? They're gonna give you that the vein's good. You want to do a FemPop bypass with a vein, that's where they're gonna push you to. So again, stress test, make sure that the heart's okay before you take them so you don't have a heart attack on the table. Just let them know you're thinking of everything, okay? Remember, you're not going to try and tell everyone that you're gonna cure cancer while you're in there. You're just telling them, hey, I know what the complications are gonna be, so I wanna check this and this to make sure that things are okay, all right? Risk factor modification, again, if it fails, which it will, you're gonna need intervention. So you're gonna tell them, hey, I'm gonna do this. If they don't have signs of ulceration or gangrene, I'm gonna modify their risk factors. I'm gonna bring them back in a couple of weeks, make sure they're doing okay. They're gonna come back with a wound or failed modification, okay? Open bypass with veins is the answer, and you want to know how to expose the femoral artery and how to expose the above and below knee popliteal artery, okay? Those are going to be your three targets that they're going to give you. You want to know how to get there. Tell them how, briefly, quickly, how you're going to get there, okay? They want you to describe an operation very quickly and concisely, know that you know what you're talking about. And then remember to perform surveillance duplex afterwards, okay? So you want to know what it is, check it so you're good. Check their signals in recovery, make sure they're improved, and then get a surveillance duplex, okay? Dialysis access, another big one, okay? So history is important. Determine what their dominant hand is to try and use a non-dominant. You want to know if it's beforehand, when their projected date is, but again, you're gonna go for it, okay? You want to know other medical conditions. You want to treat those, previous AV access or catheter. So the importance is, hey, you see this patient in your office, you're going to get blood pressures in both arms. You're going to check pulses on both sides. You're going to ask them about any central venous ports, pacemakers, anything like that. Okay, you want to know if they use their arms, does it get tired? Is their blood pressure significantly lower on the left arm? If it is, I wouldn't use it, okay? Any kind of radiation or anything like that, defibrillators, any previous trauma, any, clavicular fractures, anything like that. You want to get vein mapping. First you can evaluate them. They may say their veins look big, but I would get arterial duplex and vein mapping of the upper extremities. Look for signs of central venous occlusion, blood pressures. We talked about Allen's tests, all that. And then, the other thing is, have you had any previous dialysis access before? Okay, are they new to dialysis? Fistula first is the rule. Try and go as low as you can. So at the wrist, radius cephalic is kind of your first line if you can. Otherwise, work your way up, brachiocephalic, brachiobasilic, okay? Then a graft if all that fails. So you want to know both the cephalic and basilic veins. You want to know what the arteries are. Again, diameter greater than 3 millimeters and non-dominant hand. So maturity. You do the procedure. I want to check the patient back in a couple of weeks, make sure that the incision's healing well. I want to see him back 6 weeks later with a duplex ultrasound to determine if it's matured, okay? Maturity is diameter greater than 6 millimeters, greater than 600 mLs per minute of flow through it, and depth less than 0.6 centimeters, okay? So 6 millimeters of depth, so it's accessible. Those are the three things. You tell them that beforehand, you're good, okay? So complications, they may tell you somebody thrombosed. You want to get the clot out and look for a failure mechanism, okay? Bleeding, prolonged bleeding after needle decannulation needs a fistulogram, okay? If you see these people in the ER and they give you a patient who has dialysis access and they come in and they're bleeding after the needles are taken out, they need a fistulogram after controlling it with a stitch, okay? High output heart failure is something that I doubt they'll test you on, but just know, so progressive cardiac dilatation, and this is with high flow fistulas, okay, 2 to 4, 6 liters of flow per minute rather than 600, okay? Steele syndrome, so these are gonna be the two that in recovery they're gonna ask you about, okay? Steele syndrome happens longer over time. The other one, ischemic monoamylic neuropathy, happens kind of immediately afterwards, okay? This is gonna be something on boards that they'll ask you. So female gender, just because their arteries are smaller, prosthetic conduit, so PTFE because it is mature right away. Vein takes time to mature, so it gives your body time to adapt. And diabetes because it's a small vessel disease problem, okay? Symptoms, distal coolness, numbness and tingling. They may have pain. They're going to have some tissue loss and then improvement with compression of access, okay? So you're feeling their pulse, you're listening with a Doppler. You can barely hear anything. You push their access down and all of a sudden it augments significantly, okay? This is usually an insidious onset, affects skin, muscles, and then the nerves. diffuse pain with diminished distal pulses, okay? The difference with that and the ischemic myomelic neuropathy is that these people are gonna have unilateral neuropathy. It involves kind of a rapid form of Steele syndrome. It's gonna affect the median fibers of the forearm and the hand, and it's usually acute onset with pain and sensory loss. You're gonna see these people in recovery. You're gonna say, hey, I'm gonna go do a physical exam on them, do a history and physical, they're in recovery, and they're gonna say, hey, he's got a 2+ palpable radial pulse, okay? They're gonna try and fool you with that. Don't let it fool you. It's ischemic myomelic neuropathy. If they're having a bunch of pain and sensory loss, you take them and ligate the fistula, okay? High output failure, you're either gonna ligate or band the fistula to decrease the flow through it. I would ligate it and do a new fistula, okay? Steele syndrome, so when they come back in your office months later and they have Steele syndrome, you can work through that and say, okay, I wanna try and do a fistulogram, do an angiogram. I want to assess what my arterial inflow is, okay? So you want to make sure that their subclavian artery is patent, all right? Based on angiography, so fistulogram with compression of the fistula to see if it augments your radial and ulnar outflow, and then surgical options. So my advice is figure out one of these, know how to do it well, and don't go through the other three, okay? Give them one option, tell them what it is, and be done with it, okay? Ischemic myomelic neuropathy is, you're just gonna return to the OR and ligate it, okay? So here's your techniques. All right, banding, which we kind of did the other day. I can't remember who was in there with me, if it was, who did that one with me? Yeah, Chongus, okay. So banding, we kind of did a form of this. We kind of plicated it a little bit. So you're just trying to narrow the inflow in it, okay? Drill is a distal revascularization interval ligation. So you're sewing a conduit, usually vein, okay? You're sewing it more proximal, at least 7 centimeters proximal on the brachial artery. You're gonna sew it down distal to where the fistula is and then ligate here. If you don't tell them that you ligate here, the flow is gonna come down and it's gonna take the easiest route for the blood flow, okay? Which is back up rather than down these diseased arteries. So you want to put it proximal enough so that it preferentially goes in here, so greater than 7 centimeters. Let the blood flow go down first. I'm going to ligate just distal to the fistula, so that blood goes down the arm first, then here, okay? A proximalization of the arterial inflow, you're going to ligate the fistula down here, and you just bring it off a bigger, more robust artery more proximally, okay? So use a conduit, sew it in here, and sew it to the proximal aspect of the fistula, and I'm going to ligate the proximal aspect of the vein, okay? That's what you tell them. For a revision using distal inflow, the thought process here is that this is after the split, okay? So usually on the radial artery, it's already split to go to your dominant ulnar. You're gonna try and go down lower. So the difference between these two is the proximalization of the arterial inflow. You're coming more proximally off the artery where it's bigger, so it's likely to have more flow going down. You're gonna try and make this anastomosis a little smaller than bigger here, so it'll go here first, but then you leave coming off the larger blood vessel, you get more flow down. For the distal inflow, you're coming off a vessel after bifurcation, so it's coming down, it's splitting, and then you're coming off the proximal aspect of the radial artery and going back up, okay? I would stick to this right here. This is gonna be your most common, most successful. Just know how to do a drill, tell them how to do it, okay? Visceral aneurysms are probably not going to ask you too much about. The one you're probably going to get is going to be a splenic artery aneurysm. It's going to be a girl with abdominal pain. X-ray is going to show a calcified ring in the left upper quadrant, okay? They may even just on written boards, I vividly remember it was a 40-year-old woman or whatever with recurrent left upper quadrant abdominal pain. They gave you an X-ray and that was it. What's the answer? And you could barely see a little ring of calcium in the left upper quadrant, okay? So 33% have additional aneurysms. Screen for those, cerebral, thoracic, aortic, iliac, peripheral aneurysms. Ask about a family history. Most common splenic artery aneurysms, female to male, far more because of the hormone changes with pregnancy, okay? So ask about a pregnant female. So the reasons to fix this, okay? 2 centimeters, whoops. So 2 centimeter size, if they're symptomatic, if it's a pseudoaneurysm, okay, you're gonna fix it. And then you wanna ask, if they're a pregnant female or a woman of childbearing age, you're gonna fix it, okay? If not, it'll rupture over 90% maternal and fetal mortality, okay? Bad news. So again, calcified ring on abdominal x-ray, they're gonna tell you this double rupture phenomenon. So the patient was, has one, they're gonna tell you, hey, they had an x-ray at one point. They may even show you a picture of an x-ray. You have to pick up on that. Hey, she had severe onset of left upper quadrant pain. She got very dizzy. She felt like she was gonna pass out. She recovered, she felt better, she came in, she's still having pain, but it's not as bad as what it was. And then they show you that x-ray. You better operate on them or they're gonna go, okay? Open repair with aneurysmorphia, interposition graft, ligate, or just take out the spleen, okay? If you take out the spleen, make sure you're gonna give them the splenic vaccines. That's gonna be the easiest way to do it, okay? Splenectomy. So other visceral aneurysms, hepatic, I mean, they're not really gonna ask you much about these, to be honest with you. If it's SMA, just make sure it's not infected. Gastric, gastroepiploic, what is a reason why they may have gastric or gastroepiploic? Anybody know what would make it more likely that they have those? So a couple things. One is celiac, so that they either have, usually it's celiac artery occlusion, so you have higher flow through those kind of accessory vessels there, and they'll get an aneurysm there, okay? Yeah, here we go, celiac occlusion, so right there. All right, I highly doubt those. The one they're gonna ask you about is gonna be a splenic, okay? And then thoracic outlet syndrome, they may get into this. I've heard of somebody being asked this before. So 3 types, okay, neurogenic, which is by far the most frequent, 85 to 90. Venous is about 6%, and arterial is about 3 to 4%, okay? Caused by anatomic variations like an anomalous scaling musculature, aberrant fibrofascial band, or cervical rib. Previous neck surgery, upper extremity injury is a big one, okay? So that's usually gonna be the main thing. Repetitive motion, so they're a pitcher in high school, softball player, a swimmer, things like that, okay? They get fibrosis or muscle hypertrophy and spasm. You get compression of the brachial plexus for neurogenic thoracic outlet. You get pain with base of the neck to the fingers. They get numbness and tingling and weakness. It's often a diagnosis of exclusions. They've been to physical therapy. They've seen, orthopedics. They've seen hand surgery. They've seen all these people, and they can't really figure anything out. They've gone to neurology. They've had, nerve conduction studies and everything that are pretty normal, okay? Physical exam, complete neurovascular exam, the Tinel sign with pain radiating and paresthesias with percussion over the nerves. That's not very specific or good. The Atson test, where you kind of get their limb up, you turn their head, have them do deep breathing, assessment of the radial pulse, and the elevated arm stress test. They kind of sit here, they open and close their hand with their arm turned. It gets numb and tingly pretty rapidly if they have that, okay? The main thing for these, chest x-ray looking for a cervical nerve, MRI, nerve conduction study, SSCPs, and then, the big thing that are usually pretty good, honestly, is a scaling muscle block, okay? So they'll deaden it and see if they get relief, then it's usually a positive predictor that they're gonna respond favorably to surgery. For thoracic outlet syndrome, neurogenic, if they ask you about it on the test, this is more so going to be on the written boards than the orals. I doubt they're going to ask you on the orals, but on the writtens, for neurogenic, physical therapy is your answer, okay? You're not going to operate on those people, all right? 85% relief with 6-month PT specialty, okay? A lot of these people have a little bit of crazy in them too, so you're not truly going to fix them completely, all right? So surgery-wise, if you're doing it, supraclavicular first rib resection with anterior middle scalenectomy and neurolysis. Y'all see me do this. You take the nerves out, take the anterior and middle scaling muscle out, free the nerves, take the first rib out or the cervical rib if it's there, leave it drain, okay? Venous, so acute thrombosis, this is a Paget-Schroeder syndrome. They may give you a kid who's been playing baseball repeatedly, comes in with a big swollen arm, okay, high school kid. They're gonna have cyanosis, edema, venous distension, venous collaterals. You're gonna, again, use a picture of a swimmer. You get compression of the subclavian vein between the clavicle and the first rib. You're gonna hypertrophy of the subclavius muscle and the anterior scaling muscles. Again, this is about 60% of upper extremity DVTs is from this. Leads to PE in only about 5 to 15% of cases. And occasionally it can be due to pec minor impingement, so kind of out over here, okay? So you have to free up do a pec minor tenotomy, okay? Imaging, so really the treatment's thrombolysis if it's less than 2 to 3 weeks, and anticoagulation. So first you want to get their venous flow open, and then do a venogram to assess for stenosis with plus or minus with angioplasty, and then do an infraclavicular incision with a first rib resection of the subclavius and the anterior scalene, and then venography a couple weeks later. I was thinking I did one of these recently on a lady that had repetitive pacemakers. I don't know who did that with me, but it was pretty nasty in there. Very scarred from all her pacemakers and leads and everything. And then arterial is the least common, so 90% do an anomalous first rib or cervical rib. You get repetitive compressive injury to the artery. This will usually, the patient presents with distal emboli, okay? So the question is going to be, is some, male or female that, they're going to give you some random history, but keeps coming in with these distal emboli to the fingers, okay? Just the tips of all the fingers on one side have wounds and healing wounds and distal embolic phenomenon. They may have acute onset of ischemic pain, pallor, weakness, so you can have kind of compartment syndrome type symptoms, and then perform a thorough history and physical exam. You want to assess distally as well as proximal pulses. You want to make sure you feel under the clavicle and on top of the clavicle. They may give you that you feel palpable pulsatile mass, okay? And then a neurologic exam to assess the degree of ischemia. Imaging, again, X-ray, CTA is going to be your important one to determine proximal and distal targets, and then, your conduit-wise, PTFE versus vein here, okay? Start a heparin drip, thrombolysis, depending on if it's a thrombosed aneurysm, decompression with resection of the first and cervical rib, and then reconstruct the artery, okay? An interposition graft's the best option. These usually you're going to have a supraclavicular and infraclavicular incision. Get out kind of the proximal aspect of the axillary artery, proximal aspect of the subclavian, put an interposition graft in there, okay? Tunnel it beneath the clavicle, take the rib out so you have plenty of space, tunnel it under, sew your proximal on one side, sew your distal on the other side, and you're done, okay? Completion angiogram or a duplex ultrasound prior to leaving the OR to make sure they got flow, okay? Check your distal Doppler signals as well. So again, for supraclavicular rib resection or scalenectomy, so head turn contralateral, neck roll under the patient. I usually put it vertical rather than horizontal, so down the middle of the back so it kind of flexes their shoulder blades out. Supraclavicular incision approximately 1 to 2 centimeters above and parallel to the clavicle. Create subplatysmal flaps. Divide the clavicular head of the SCM. IJ goes medially. Watch out for the vagus. Watch out for your carotid. Mobilize the scalene fat pads superior laterally, okay? Tie off lymphatics. If it's on the left side, tell them you're looking out for the thoracic duct. It prevents you complications in the future. Look out for the phrenic nerve, which runs on the anterior aspect of the anterior scalene. It's going to be going medial to lateral, okay? Which is one of the interesting courses, the interesting course for it. Get the anterior scalene off the insertion at the first rib and then superiorly, kind of up around C3 really. Free the brachial plexus on the anterior aspect of the middle scalene, resect the middle scalene, working from down to up because sometimes your brachial plexus can kind of split between there, so you don't want to bag one of the branches of it. And then resect your first rib after removing the intercostal muscle from the inferior surface and the pleura from the posterior surface, okay? Leave a drain. So this is going to be the other way if they're going to ask you to get to your, like from a trauma perspective or something, to get to your subclavian artery, okay? So same type exposure. Complications, phrenic nerve injury, brachial plexus, long thoracic, suprascapular, dorsal scapular, injury to the artery of the vein, pneumothorax, lymphatic leakage. So again, put a drain in, okay? Low-fat diet, parenteral nutrition, open surgical ligation. They're going to take you down the road. You may have to put a scope in and thoracoscopically ligate it, or endolymphatic embolization. I'm not going to ask you about that, but that's an option.
Okay, everybody, if we don't have any questions or comments, that is a wrap for this morning. Have a great day. Thank you, Dr. Rideout,
Yep,
for this
thank you.
excellent presentation.